Hi, I'm Betsy O'Donnell from the Dana-Farber Cancer Institute, and I'll be talking to you a little bit about our presentation here at IMS in Toronto about quadruplets. We know that quadruplets are now the recommended frontline therapy, and the question is, how do we optimize them? And so there's a lot of exciting things still reading out in trials that have already been done about quadruplets in comparison to triplets. But really, I think some of the unanswered questions are, how do we approach maintenance for individuals? And can we take a risk-adapted strategy to best meet the needs of our patients? For example, if someone has achieved MRD negativity, can we de-escalate therapy for those individuals? And conversely, if someone has not achieved MRD negativity, should we escalate or intensify therapy? With the hope being that we don't overtreat some people who don't need it, and that we don't undertreat people or introduce toxicity unless we really need it. So I think these are some of the exciting things that are going on, and I think very conclusively that we see, whether it be transplant-eligible patients, which is what I talked about today, or transplant-ineligible patients, the data really strongly support using quads for newly diagnosed patients. So when we think about the utilization of MRD, so minimal residual disease in individuals, there are certain time points within clinical trials that we do these analyses, understanding that the lower we go, the longer the remission typically lasts. Some people get into that MRD negative remission relatively quickly, whether it be through 6 or 8 cycles of our therapy, whereas others don't reach that point at the end of consolidation. And so one of the ways that we're thinking about clinical trials, MRD has always been used as an endpoint, but can we now use it as a pivot point where patients take the next step in therapy based on these results? If they've reached MRD negativity, can they go on to maintenance? Can they back off maintenance? If they're persistently positive, do they need to undergo that transplant? Should we change therapies, or should we keep them on multiple maintenance therapies, trying to get a deeper response over time and a more lasting one? If you're going to do a test, then you need to be using the information from that test to change it. So if you're going to base your clinical management on MRD testing after a transplant in terms of determining maintenance, then absolutely. If you're going to use that MRD testing after you've done induction to determine whether or not someone should go on transplant, then absolutely. Whether or not, if you're just going to do it for the sake of knowing but not change anything, that's more of a hand-waving, don't know what the right answer is. But I think if it's going to become something that helps you in your clinical care, then absolutely it's worth sending it when you do a bone marrow biopsy.